Good morning, good morning, good morning, and welcome to the Great Lakes Health radio program here on WUFO, Power 96.5 FM and 1080 AM. I'm your host, Francesca Messiah, Manager, Workforce Development for Kaleida Health. And at Kaleida Health, our mission is to advance the health of our community. And that's what this radio program is about. It's about advancing the health and the educational knowledge about healthcare of our community. Many times I've often asked in the community, who is Kaleida? People confuse us with health insurance, but we are the hospitals. What hospitals are we? We're Buffalo General Medical Center. We're Gates Vascular Institute. We're Oishei Children's Hospital. We're the Hospital Without Walls, Visiting Nursing Association. We are Millard Fillmore Suburban. We also have an emergency center at DeGraff, and that's in North Tonawanda. We have two long-term care centers, and one is at DeGraff, and the other one that's, again, in North Tonawanda. And our other location is on Michigan and High, and that's High Point. We have clinics for everyone's needs. We have clinics for in Buffalo and in the South and North towns for adults. We have it for children, our pediatric clinics. We have clinics specifically designed for moms or women who would like to get pregnant. And we also have the Family Planning Center, which is, again, a clinic that works a lot with teenagers, but again, with adults as well. Also, I would like to make you aware that at Kaleida Health, we are hiring. We have hundreds of positions available. If you go online to Kaleida Health, go to your search engine, type in KALEIDAHEALTH/careers, and it should come up. If it doesn't come up right away, give it a try again in a few minutes. And we are hiring for positions that require high school degree or GED, all the way through advanced certificates and advanced certificates and college degrees, all the way through PhD. And of course, nurses. We are always hiring in that area as well. So I just want to make you aware that please check out our website for jobs, because we want you to join our Kaleida family. Well, so today's topic, we have talked on more than one occasion about stroke. Why strokes? Because strokes impact African American community. And we here in Western New York have some of the highest stroke rates. So today's topic is called strokes, testing your knowledge. I'm hoping that today, when you hear Dr. Hahn, good morning, Dr. Hahn, how are you?
Hi, good morning.
Good morning. I am hoping that as you hear Dr. Hahn, who is a vascular neurology fellow, that when you hear him, that you will also know the answer to the question. So that's why I'm calling it stroke, testing your knowledge, because it impacts us the greatest. And again, we're advancing the health of our community, advancing the health through educational knowledge. So we're going to start. Okay, Dr. Hahn, how are you this morning?
I'm good. Thank you. Thank you for that introduction, and happy to be here.
And welcome, because I know this is your first time appearing on the radio program, isn't it?
Absolutely, yes. I only came to Buffalo in July for training, and it's been a great time here.
Oh, good. Oh, great. Well, Dr. Hahn, here is the first question. We often hear the word stroke, and sometimes we panic. Not sometimes, many times we panic. But what is the difference between a stroke and an aneurysm, and a stroke and a mini stroke? It seems like many times these terms are interchanged. So can you just help us understand the difference between a stroke and a aneurysm, which is a brain bleed, I believe it's called, and a stroke from a mini stroke?
Absolutely. Great question. And I come across this a lot with patients as well. So to define stroke briefly, and I will try not to use too much medical lingo, is that when you have some kind of symptoms that may be due to a blocked vessel. Now, as far as those symptoms are concerned, we always use the be fast sort of mnemonic. So balance, eyes, face, arms, speech. So weakness, difficulty seeing things, your face drooping, difficulty speaking or understanding what somebody is saying. Those kind of symptoms are considered a stroke. So stroke is a clinical diagnosis. You see this in front of you, you should be concerned about the patient might be having a stroke. And perhaps the most important thing about this is that it is sudden in onset. Out of nowhere, it's sort of like an instant switch. You immediately have these symptoms, and that sort of is a hallmark of having a stroke. Now, the other things that you mentioned of the aneurysm and things like that, roughly we divide strokes into two broad categories. One is ischemic stroke, where there's a clot that is, snaps a vessel shut and it causes a stroke, which is the clinical manifestation that we see. And then we have hemorrhagic strokes, or brain bleeds, as we like to call them. Now, those can be due to different reasons. Now, aneurysm is a cause for brain bleeds. So it is not a brain bleed itself, but because of that outpouching of the vessel, which is an aneurysm, if it ruptures, it can cause a bleed in the brain. So it's you're very right that all of these things sort of fall under the blanket term of stroke. And then the same thing is the mini stroke, which in our lingo, we refer to TIAs, or transient ischemic attacks, in which you have these stroke symptoms, but they sort of resolve. Or when we do imaging, especially MRIs, we can't really find it. So it was sort of like a near miss as far as strokes are concerned. And they themselves are also scary because they can be sort of an event that can precede a bigger stroke. So we do take them very seriously as well.
Thank you. Now, in Western New York, are you aware of it? And I said it earlier in the show that there's a high percentage of people who have strokes. Is that still true, according to your
Absolutely.
research?
So just to put some numbers out there, just this burden of stroke. This is from the latest AHA updates, the American Heart Association, that in 2020, stroke accounted for approximately 1 of every 21 deaths in the United States. In the same way, age-related, these strokes, stroke ranks as number 5 among all causes of death in the United States, causing roughly 160,000 deaths in 2020. As far as New York itself is concerned, about 6,004 of them every year. Now, at the same time, perhaps the most important thing about these situations is that not all strokes will end up in death. It is the leading cause of disability as well, which is, which in itself is quite a big problem. So, for example, one half of your body is not moving, you're significantly disabled, among other symptoms that you can have. If you can't see from one eye or both eyes, again, that's a significant amount of disability. So perhaps disability is an even more important discussion than just deaths or mortality. So like I said, it's a very significant population that gets affected by this.
Back to mini stroke, because sometimes I've heard people say that, oh, it was just a mini stroke, it doesn't really matter. And so my question is, doesn't matter. Does it matter? And I think Nicole has just joined our conversation. But is a mini stroke important, and should it be taken seriously?
Absolutely. Very good question. It is very important. So these symptoms that are sort of you have them and then they're resolved over minutes or hours or whatever it is, or the TIA, the word that we use in our lingo, or transient ischemic attack or mini stroke. These can be precursors to a larger stroke. So it clearly shows that that blood vessel is struggling. It's about to it's going to sort of this end of it, what it can do for the brain. So, which is why it's very important. The highest likelihood of having another stroke is actually within the first 24 hours, and this sort of keeps on going for roughly a month. So, which is why it is very important that even if you've had symptoms that are transient in nature and they have reversed, you should still seek medical attention for them.
Okay, yeah, thank you. Because I just had to ask that question, and I know I've asked that question before to our listeners. Before we go any further, I want to introduce Nicole. Nicole, you've joined us on the call.
Hi, how are you?
Good. How are you, Nicole?
I'm doing good.
And Nicole, could you just give us your title again, so for our listeners?
Yeah, my name is Nicole Hames. I'm an RN here at Buffalo General. I'm also the stroke coordinator for Buffalo General Gates Vascular Institute. So I help coordinate the stroke program here.
Oh, great. Thank you. So you're part of the stroke education.
Yes.
Okay. And that's what we are definitely talking about today, stroke education. Okay. Well, Nicole or Dr. Hahn, or both, if you'd like to answer the question, who is at the greatest risk for getting a stroke? And if someone in your family has had a stroke, so after answering that question, is it hereditary? So who is at greatest risk at developing a stroke, and are strokes hereditary?
Right. Is it fine if I talk about it, Nicole?
Yes, go ahead.
All right. So perhaps the most important risk factor for having a stroke, that was the first part of the question, is smoking. So smoking itself is so dangerous and it's so bad for the blood vessels that even if we give them the best medications on the market, it still doesn't matter. If they continue to smoke, they will continue to have significant risk for having strokes because of the amount of damage that it does to blood vessels, among every other organ that it pretty much damages in the body. Then perhaps the other one is physical inactivity and nutrition. So a lack of exercise and not eating healthy, not having a balanced diet can also further put you at risk of other risk factors for a stroke, like diabetes, hypertension, high cholesterol, things like that. So that in itself is another one. And of course, then it goes on to cause obesity as well, which in itself is a risk factor. And then, of course, like I talked about, cholesterol, diabetes, hypertension, these things are important. And something that has become more important more recently is inadequate sleep. So people might be surprised. It's like, what? It's like, just sleep? But it has been proven by research that the American population is struggling to get adequate sleep. And research has shown that this in itself can be identified as a risk factor for developing many neurological diseases, such as cognitive problems and dementia, but of course, stroke as well. So so as you may see from all of this, like generally, quote unquote, healthy lifestyle, because only a healthy body can house a healthy mind.
Mm-hmm. Thank you. Nicole, I'm part of that committee, so I see you all the time, the stroke committee. So, and we talk about a stroke patient coming into the hospital. Could you just explain what's the role of the nursing staff? I mean, I know there's so many roles when that patient comes into the hospital, thinking it's a stroke or maybe it's an aneurysm. Please explain to our listeners, what's the role of the nursing staff, and how quickly do they jump in after the person has taken off the ambulance, if they come in by ambulance?
Yes. Yes. So, I mean, obviously, we do prefer everybody to call 911 and come in by ambulance. A lot of times the ambulance will give us a pre-arrival. So, I mean, our team's already at the door anyway, but if we know a stroke is coming in, just give us a little more time to prepare. But yeah, the role of the nursing staff, when you come in with a stroke, you will see the triage team. Everything will in the beginning will look a little overwhelming just because everybody wants to get you treated as fast as possible, get you to our CT scanner. So they'll do things like running EKGs, getting some blood work from you. Well, they'll take you over to our CT scanner, but you will always have a nurse with you at all times during the process. We're there 24/7. We do frequent, you might hear us asking you a lot of questions, like constantly asking you, like, what's the date today? What is your name? Because we just want to monitor you and make sure that you're still doing okay. As far as that, there'll be a lot of tests, a lot of doctors coming in. But as for the nursing staff, like I said, they'll always be by your side. After the ED, if you do get admitted, you will go to one of our neuro units. So we have nurses that are specially trained for taking care of patients with strokes. The nurses also are there to educate you and tell you what's going on. But that's what our team is for.
And I guess, Nicole, I should have said, based on real life experience, if that person cannot talk, cannot communicate, it's okay for the family member to be there, right?
For sure, yes. Yes, we encourage it.
Yeah, I just want to make sure that family members know that if your loved one has had a stroke, a brain aneurysm, even a mini stroke, you want to make sure you stay with them to answer the questions, because anytime you go into the hospital, there are going to be a lot of questions. And so you want to be right there by their side. And if you can't, you got to ask, why not? But you want to be there by their side. So you can answer those questions. So the doctor, right? So Dr. Hahn and his team can treat you and the nurses can treat you. Am I correct?
Yeah,
absolutely.
Yeah, we encourage it because a lot of times it's scary, especially if you can't talk. So you would always want to have your family member or somebody by your side who you're familiar with that can kind of comfort you, and because you're in with a bunch of strangers and you can't talk. So we definitely encourage family.
Yeah. I would go far enough to say that it's very important because they also give us very critical information on onset of symptoms and the nature of symptoms, which is very important for us to make decisions at that time. So
how quickly when the person comes into the hospital, either through an ambulance or maybe they, heavens forbid, they could have driven themselves or a loved one could have driven them. How long does it take to, or estimate length of time to tell that person if they've had a stroke or aneurysm? How long does all that take?
So it's very quick. So the way that they come to us is that we do our initial evaluation and we get our scans immediately, and within 15 to 20 minutes, we're ready to give them the treatments that they need. But timeline-wise, I think it's a very important question that you asked, that they need to come as quickly as possible because there are some options of treatment. More importantly, an IV clot-busting medication that can only be given in the first 4.5 hours of the symptoms. So if they miss that very golden and very important window of 4.5 hours, then we cannot give them clot-busting medications. It's actually even better if it's sooner than that, because outcomes are better if it's within 3 hours or even earlier than that. So I think that's a very important thing that needs to be spread everywhere, that coming in as quickly as possible with a family member is the most that you can do for that patient.
Yes. And again, I'm some of these questions I'm asking based on experience. So thank you. I want our listeners to know, because again, today it's strokes, testing your knowledge. You talked about disabilities. What kind of disabilities can a stroke cause?
So it can be because after all, our brain, controls everything. So it can be, like I mentioned, if you have balance problems, then you can have difficulty walking. If you have difficulty seeing, then again, it's difficult to drive. It's difficult to move. It's difficult to hang on to things. You can have swallowing problems. Unfortunately, a lot of our patients have swallowing problems, irrespective of where their stroke is. So for that, they might need some kind of assistance, or even like a tube that gives food right into the stomach. I know it sounds scary, it sounds horrible, but it does happen. Then you can have weakness of one side of your body, or in very rare cases, both sides. So of course, if you cannot move, if you cannot grab things, that's disabling. And then of course, speech in itself, difficulty understanding what people are saying, or difficulty getting your words out, or even if you do get them out, they don't really make sense. So these are sort of the spectrum of the different things that can cause a significant amount of disability.
Mm-hmm. Nicole, do you see a lot of disabilities from the patients when they first come in?
Yeah, like it does. It has a range. I mean, everybody is different. Some people don't have some disabilities, and some people do have very debilitating disabilities. So it's very different depending on what kind of stroke it is, where it is in the brain. But yes, we definitely do see some. I would say, as some of the research I've been doing, as far as stroke education and symptoms, a lot of times people are coming in now with like atypical stroke symptoms. So it might be things like loss of vision that they've had for days that didn't want to get checked out, or numbness and tingling, or they said their leg felt heavy. So some trying to just spread to the community some of the atypical stroke symptoms that definitely get checked out, because you never know, it could be a stroke. But we do see disabilities coming in. Yeah, but it varies, person to person.
Yeah, thank you. And for our listeners, I guess the question is, if your loved one all of a sudden starts saying that it seems like their sight is going bad, do you take them to an eye doctor, or do you bring them in for a stroke? Especially, I'm going to ask our experts. So if your loved one all of a sudden begins rubbing their eyes, having difficulty seeing from their eyes, I mean, should you bring them in, or should you wait and see if it's just something with their eyes, or might that be a stroke they're beginning to have?
So I would definitely bring them to the emergency department for an evaluation, where if it turns out to be just an eye problem and not from a stroke, they can get adequate treatment for that, because there are eye-related emergencies as well that are not stroke, glaucoma being one. So I think it's a good idea, if that is happening, that you come and get checked out, at least in the emergency department. At least let the professionals do an evaluation if this is from a stroke or if it is not from a stroke. I think the key word here is sudden. When anything like that happens suddenly, it is concerning.
Yes. I mean, and even as small as, and I have to say, this is a personal experience from a loved one who all of a sudden really couldn't lift her arms. And I knew she was I knew she had a stroke, because there are all these things that all of a sudden had happened. And from serving on the committee at Buffalo General, Nicole, working along with your predecessors for years, they have trained me well on what to look for. So that sudden is very true. How about prevention? Let's move on to prevention. Dr. Hahn first, Nicole second. What are some prevention methods to avoid a stroke?
Excellent question. So definitely, there's a lot that one can do for prevention. Like I talked about the different major risk factors for stroke. So the top of the line is definitely smoking. So smoking cessation, establish care with a primary care doctor. Even if you're not diagnosed with a lot of things, it's probably a good idea to see your primary care doctor once every 6 months or once a year to see, all the systems are working fine. If you've not developed blood pressure, your cholesterol, check if you have diabetes or problems related to that, then work on your sleep hygiene and try to get enough sleep. And at the same time, work on your nutrition and get exercise. Exercise and good sleep and nutrition perhaps do the most apart from smoking for you, because prevents all these other risk factors that you can develop, and then eventually those can develop into stroke. So go get your exercise. If you can run, just walk, just do something, some kind of physical activity.
And Nicole, you're a nurse in the hospital, and and I know many times nurses are on the floor. It's hard to move through the lens of a nurse. And we're saying to get exercise. What do you feel is something that well, because many of us can't get out, not just nurses, but what are some areas of prevention that you would recommend?
As far as areas of prevention, yes, you do have exercise, like Dr. Khan was saying. There is a lot of exercise you can do if, from your home. There's a lot of home exercise things. I mean, just even get up and get moving. As a nurse, I think I would say the biggest prevention is watch your blood pressure. Because you do have your hemorrhagic strokes as well. So a lot of times, people don't watch their blood pressure, or they don't take their blood pressure medication. And then, we have hemorrhagic strokes that are caused from that. So, I would just say, keep up with just getting your blood pressure checked. There's lots of ways you can do that. And you meet with your doctor to make sure you're on some kind of antihypertensive medication. I would say that's a big one, for prevention, as well as, like he said, the smoking, the eating healthy, and the exercise. I mean, if it's anything, little bit of exercise that you can do, even just in your living room, if you can't get out, anything is better than nothing.
Or if you work in a large hospital, like we do, Buffalo General, or any of the hospitals are, Millard Fillmore Suburban, Oishei, like walking through the hospital or taking the stairs. Is that also a good form of exercise?
Yeah, and I know there's a few people that I think it's called Silver Sneakers. There's a lot of groups like that. They do a lot of indoor walking. There's a lot of indoor walking groups you can find now. So there's a lot of other activities. Yeah, even like walking in the mall, or like you said, in the hospital, pretty much anywhere. Or even just stand in your living room and just do like a little marching in place from time to time, just so you're not sitting still in the same spot. Anything, and then it'll help your energy level, which therefore will help your sleep.
This is true. Or if you're like me, I can't drink coffee after 12, and too much sugar keeps me up. So I have to watch that, because then it impacts sleeping at night. Okay, we only have a couple minutes left. Dr. Hahn, what would you like to share in your 30 seconds?
Well, first of all, thank you for having me. And secondly, what I would tell all the listeners is just to focus on these different risk factors that we talked about, because we can prevent this. And if we don't have it, then just remember the mnemonic: be fast, balance, eyes, face, arms, speech, and of course, time. Time is of the essence. If you see these symptoms, if they're sudden, please come to the emergency department and we'll take care of you.
Thank you. And Nicole, what is your last 30 seconds you'd like to share with the listeners?
Kind of just to reiterate what Dr. Khan said, just look at the risk factors. But sometimes you can still have strokes even if you don't have risk factors. I think the biggest takeaway is, if you're having symptoms, get to the hospital. A lot of people think, well, I don't have the risk factors so therefore I'm not having a stroke. So, it really could happen to anybody. So just, recognize those symptoms. It doesn't matter. Sometimes it doesn't matter if you stroke, or, we've had strokes in 20-year-olds. So it's like, it doesn't matter, just whatever symptoms you have to have, or if it's a family member of yours, just really you have to encourage them. There's some people that you just have to push to seek medical attention.
And you might have to push them in the ambulance or driving them, because not all family members want to go to the hospital. So, you might have to put a little pressure on your family. Well, we've come to the end of our program, Strokes, Testing Your Knowledge. It will not be the last program on stroke, because there are just so many strokes. 1 in 5, was it 1 in 5 people I wrote down, 1 in 25, but strokes are very prevalent. As one in every 21 deaths, and many of them impact African Americans. We didn't even talk about that today, but I just want to thank Dr. Hahn. Thank you, and I want to thank you, Nicole Hyams, for being our guest this morning on the Great Lakes Health radio program. And I want to say, listeners, don't touch that dial. We still have another half hour. So thank you, Dr. Hahn, and thank you, Nicole.
Thank you so much.
Thank you.
And now on to part two. Good morning, Kelly Cardome. How are you?
Good morning, Fran. I'm doing well. And yourself?
Oh, I'm doing well. And listeners, I just want to say welcome to the second half hour of the Great Lakes Health radio program with Kaleida Health. And if you're just tuning in, it's 7:30 in the morning. I'm Francesca Messiah, Manager of Workforce Development from Kaleida. And our topic for today, as Kelly and I, we talk a lot on nutrition. And our topic for today, seeing as we are approaching the holidays, is type 2 diabetes and pre-diabetes and eating during the holidays and into the new year. And the reason for this topic, and Kelly will correct me, I just want to say Kelly is a clinical nutrition and diabetes program manager for the primary care practice of General Physicians. She has her master's. She's a registered dietitian. Kelly has about 5 initials degrees after her name, but she is soon to become Dr. Cardamone, right?
Yes. I'm working on my doctorate in clinical nutrition. So hopefully I'm more than two thirds of the way there. So we're making progress. It takes a while.
It does. And now, Kelly, what is it you told me? 1 in how many people are diagnosed with pre-diabetes or type 2 diabetes? What was that?
Yeah, so about 11% of the population currently has diabetes, but about 1 in 3 individuals under the age of 65 has pre-diabetes. So if you think about combining those two numbers, you have 40% of the population, more than 40%, that is experiencing insulin resistance. And really need to be mindful of their diet and behaviors, exercise and things like that to help control their prediabetes or diabetes.
Thank you. And so if someone is pre-diabetic, and I get this, I hear this a lot, how close, I guess it's the numbers, right? It's in your blood test, but how close are they then to possibly becoming type 2? Because I have a lot of people out in the community, and when I'm doing outreach, and I'll ask them, "Do they have diabetes?" and they'll say no, but they're pre-diabetic. What does that mean, and how long does it take to become type 2 diabetic?
So it's a great question, and I'll share some statistics with you. So I will share it's not a straightforward answer because there are many factors that are involved. So I'll start off with the factors, and then I'll give you some of the stats. So to just develop diabetes, right? So again, that puts you in that risk for developing prediabetes. So family history is a huge factor. So if you have a first degree relative that has diabetes, you have a 25% greater chance of developing diabetes if you have 2 relatives. So it kind of increases based on how many people in the family. So a stronger family history. If you have a BMI over 25, so that's considered that's the body mass index, height and weight. Between 25 and almost 30 is overweight. 30 and above is obese. I just want to throw another stat out to you. We've got over 40% of the population meets the criteria for obesity. And then you have less than that, but over 35%, give or take, now that is overweight. So we have 3/4 of our population that meets that BMI of over 25, right? So that's a risk factor. Just age alone, you can't change that. 45 and older put you at risk. But things like your BMI, you can change. Family history and age, you cannot change. But being inactive, that's a risk factor. You can change that. Smoking, having PCOS, which is polycystic ovary syndrome, or having a history of gestational diabetes put you at higher risk. So gestational diabetes is diabetes while you're pregnant. That alone puts you at a 60% we call lifetime risk. So it increases your lifetime risk of developing diabetes. Now, to put that into perspective, because you asked about prediabetes, so I kind of reviewed these risk factors. Well, now we get into, if I have prediabetes, what are my chances? Well, you want to look at all those risk factors I just went over. And it's like, hey, which one of those can I change? I can change being inactive. I can change the way I eat, which should ultimately change or help improve my weight or BMI, right? If I'm smoking, I can quit smoking. But if you are, according to the American Diabetes Association, if you are 45 years old or older with prediabetes, your 10-year risk of it turning into diabetes is about 9 to 14%.
Wow.
So, yeah, but I will share that the older that you get, it does increase that risk. But there are people that, I don't want to say hang out, but stay in that prediabetes range most of their life. So there's a lot of it in your hands.
Okay. No, thank you. And what made me think about this topic for today was holiday and New Year's. And because the number one New Year's resolution, people always say they're going to either exercise more or diet. So I said, seeing as this is December, why not get a jump start? So let's talk about starting with the meals, breakfast, lunch, and dinner. And I've heard you don't necessarily need breakfast, lunch, and dinner, but that's neither here or there. But what should you do this if you like, let's say scrambled eggs, you like butter, you like cheese, and your eggs, maybe you put a little something in them. So in terms of your meals, breakfast, lunch, and dinner, what should we be cognizant of? What should we say, do this or don't do this, and now do that, something like that?
Sure. So eat this, not that.
Eat this, not that. Exactly. Yes.
So, yeah. So the thing is, and you're right, we don't necessarily need 3 meals. We could do a whole nother show on that. I do like intermittent fasting. I definitely think it has its place and its benefits. But again, that's a whole nother show. But you know, when you're looking at your meals, the biggest thing to remember is you want to balance out your meals. And so I'll say, eat this. Make sure you have a protein with every meal. But as soon as I say protein, most people think of chicken and meat and burgers and meatloaf, and that's not it. Protein sources can also come from beans, legumes, nuts, seeds, tofu. So on that note, I do tell patients, try to make half of your protein intake plant-based. Doesn't have to all be animal-based. Or eggs is another one that's pretty common. So you want to make sure you have protein in those meals. If you can add vegetables to your meals, go for it. I just made an egg white bake, and I do egg whites, and I use what they call nut cheeses. So they're cheese that is made from nuts, and I put tons of vegetables in there. So if you do things like that at breakfast, lunch, and dinner, that fiber is great for your gastrointestinal tract, good for your cholesterol, regulating blood sugar, satiety, just overall keeping you nice and healthy, because we don't eat enough vegetables. So try to get, I should say, fruits and vegetables in at each meal. And then it's okay to have the carbohydrates, but even if you're going to do something like an English muffin or pasta or rice, you want the whole grains, because you want, again, that more fiber. So that's kind of what you want to focus on doing. Now, what do you want to avoid? You really want to be mindful of, as Americans, we do, it's, I've mentioned this before, the standard American diet, it's SAD, right? That's what it stands for, the acronym. We tend to eat a lot of saturated fat, and we tend to eat a lot of fat overall. And there is a difference between fats, butter, oils. Like if you're looking at meat and you see all the grease and the fat, those aren't great for you. So you want to choose the healthier fats like avocados, nuts, seeds, olive oil, avocado oil. If you're using a spread, use a vegetable spread that doesn't have the hydrogenated oils, that's made with olive oil or other vegetable oils. You want to try, this time of year, everybody's into baked goods and cinnamon buns and, things like that for breakfast. Don't start your day off with sugar. Start your day, because it really does kind of sabotage the rest of the day for many people. And then bottom line is portion sizes. Try to space out, don't make your heaviest meal at night. especially people tend to eat late this time of year if they're getting ready for holidays and doing things, because it's really can be disruptive to sleep. So really try to space out those meals. And if you're going to have a larger meal, make it lunch or even breakfast over dinner.
Okay. Now, and then I also want to say, you say don't have your heaviest meal at night, but that doesn't mean if you're having a light meal to then have a nice slice of chocolate cake, right?
Right. Absolutely. And that's the thing where this time of year, food should be enjoyed, and it's okay to have some cookies or cake or dessert. But, I call it the 80-20 rule. 80% of your diet should be whole grains, fruits, vegetables, lean proteins. Allow that 20% for flexibility. For some patients, I even recommend 10%, depending on what their current health status is. But that's where you have a little flexibility. Have a taste of something. Don't eat half of a cake.
Right. Okay. And I just have a question. Does avocado oil taste like an avocado?
No, I use it all the time. I actually bake with it. So if I was baking something and it asked for vegetable oil, I use avocado oil quite often. And it has a higher smoke point than many of your olive oils. So if you're, if you're going to use a little bit in a pan, if you're lightly pan frying or sauteing, avocado oil is a great choice. It has a much milder flavor than most olive oils.
Oh, okay. All right. I'll have to go out and buy some. I always wondered would it taste like avocado. How about if someone is concerned about his or her cholesterol? Is it the same type of what you should watch, or is there anything if you're looking at your cholesterol that you should pay closer attention to? If your numbers, if you somewhat know your numbers, is there something you should pay closer attention to?
Sure. The biggest thing, now some of it can be familial. So if you have a family history, it makes it a little more challenging, but your provider or doctor will be looking at the ratio, looking at the entire lipid panel from total to triglycerides. They look at everything, right? But what you can do on your end is, again, that fiber is extremely important. It can help to lower the bad cholesterol and total cholesterol. So eating things like oatmeal and whole grains, avoiding white processed foods, again, those fruits and vegetables. You really want to limit the saturated fat. So when you are even choosing protein sources, try to choose leaner proteins. Fish is a great choice. If you're looking at a diet to follow where we've had some great research on, there's many diets out there that work, right? And you'll even hear about ketogenic and all that. The bottom line is I tell everybody, you want a diet that you can stick with and that is financially, right, you can afford to follow. Mediterranean diet is great. So it focuses on those good fats like the avocado, the nuts, the seeds, not a lot of cheese. Cheese has a lot of saturated fat. So when you are looking at a food label, you don't look at the cholesterol on a food label. The cholesterol in a food does not raise your cholesterol, but the saturated fat, the trans fats do. So that's where you want to limit. And that's the bad fat. That's the stuff that's solid at room temperature, like butter, right? Or like shortening. Those are all solid at room temperature.
People talk about plant-based. You see plant-based, everyone has plant-based. But I don't really know. I don't know even if our listeners really know. What is plant-based? We have plants in our home, and I don't think they're talking about eating our plants. What is plant-based? What does that mean?
Yes, I would not advise, chewing on your front lawn or eating your, eating your plants in your house. But plant-based, if you think about it, really are things that are coming from the earth or are grown. So it's really avoiding anything that comes from an animal. So your eggs, your chicken, your dairy products, those are all butter. Those are all animal products. So plant-based really for the most part is anything other than that. I want you to think of it as focusing on, again, fruits and vegetables, right? They're grown. And then also your grains, again, your whole grains, but choosing, everybody gives potatoes a bad rap. White potatoes are great for you. They're really high in potassium and the skin has a good amount of fiber, sweet potatoes. So it's avoiding or limiting I should say, products that come from an animal. And it's, I tell everybody, so that rule of like at lunch or dinner, make half of your plate vegetables, meaning do salads, do roasted Brussels sprouts, and, be adventurous. The plant-based, really, there's some really great research on plant-based and how it can improve your health. And a lot of times I think people think it's more expensive. It's actually less expensive. Things like beans and black beans and fava beans and garbanzo beans or chickpeas, they actually are a lot less expensive than meat products. So that's what plant-based is primarily. But I just want to throw out one thing here. You're going to see there's a lot of what we call these meat analogs, or these kind of fake meat products, right? And I won't give any specific name brands, but you're going to see like these burgers that taste like beef, or the sausage, or that is not healthier either. And so if you're doing a true plant-based diet, you want things that are less processed. It's okay to have those things once in a while, but you are shifting from having, let's say, grass-fed meat, or people are having fish. Now they're going plant-based and they're eating these processed fake foods. And they tend to be really high in saturated fat because a lot of them are made from coconut oil. Not a great choice either. And they're expensive.
Mm-hmm. Yes. Yeah. Yeah. So coconut oil, sometimes it's used as a hair conditioner, but it's not good to eat.
Yeah. I use it sometimes when I'm making popcorn for my kids. It gives it a nice flavor, but it's a tablespoon once in a while, but you are right. It's great for your skin and hair if you want to use it.
But not for your arteries necessarily.
No, not for your arteries.
How important is drinking water? Again, it's holiday time. Sometimes we're just, there's just more spirits. There's more alcohol at parties. How important is drinking water when you're diabetic, pre-diabetic, or watching your cholesterol? Is water important to drink?
Absolutely. So you can go quite a long time without food, but you cannot go without water because your body can't just make water. And you use it, when you're breathing and you're constantly releasing or losing water, I should say. So about 60% of the adult body is water. And it's really not even just important for diabetes and everyone, even including children. So it keeps the joints lubricated. A lot of times if you have migraines, headaches, your body wants to stay hydrated. And it's great for the kidneys. So it is really important. You'll see this 8 glasses a day. There actually is no scientific evidence that says you need 8 glasses or 64 ounces a day. We base it on weight. And you, by the way, can drink too much water. I do have some patients that have been drinking 2 to 3 gallons, which is an excess. You don't want to do that. But recommendation, I do tell most people aim for 64, even up to 100 ounces a day. Or if you've got those 16-ounce bottles, at least do 4, if not 6. And you have to remember, though, Fran, that fluid to keep you hydrated comes from fruits and vegetables. It can come from if you drink green tea or coffee or soups. Anything that's really liquid at room temperature will count as hydration. But aim for a good 48 ounces of straight water. I mean, you can flavor it a little bit with lemons, limes on a daily basis. And I will just say, though, if you have severe or advanced kidney disease or other conditions, sometimes, or you're on a diuretic, sometimes your provider will tell you to limit water intake because of your medical condition or fluids in general.
Mm-hmm. And I've noticed that some of the flavored water, they have in the grocery store, there's a whole section now of things you can flavor your water with, but some of them are loaded with sugar.
So your best bet for that would be, again, throwing in a couple lemon slices, cucumber slices, cinnamon sticks. You can be really creative. If you have pre-diabetes or diabetes, I would avoid those that have sugar in them. And those would be a lot of the powder mixes and, things that you can add in. More of the sports. I have people that drink sports drinks and they don't exercise. And sometimes you need them for other medical conditions, but most people don't need those. But choose the ones that are, they'll be made with artificial sweeteners, but there's a couple of them out there that are made with like stevia and monk fruit. So if you want to choose a more natural, non-caloric or non-nutritive sweetener, and you just put a couple drops in your water to flavor it. That is great. My golden rule, as I think I've shared many times, but there could, be new listeners, is when you're looking at something per serving, go to the total, look at the total sugars on the nutrition facts panel, keep it under 10 per serving. So single digits only. And that's just an easy guide for people.
And I noticed that I've even started the other day. I was in a store and they had soup, different, brand name soups on sale. And one of them had 3 different types of chicken noodle. And I was amazed at the sodium content and how different it was for each. 2 of them were like 800 milligrams. And the other one was like 420 milligrams of sodium in that can of soup. And I chuckled because it was all the same name, chicken noodle. But reading the labels, I would say if you're looking for a New Year's resolution, it would be to read labels. Begin reading the labels.
Absolutely.
I know the print can be tiny, so you might have to bring your glasses or something with you. But reading the labels is very important. What do you think about the reading? How important is reading the labels?
Very important. So anyone that comes into the office to see me, or the diabetes classes that we offer, it is one of the foundations of nutrition is reading labels. Now, ideally, we'd like you to eat less processed and labeled foods, but that's not realistic in today's world, right? With convenience, and we're busy but read the labels when you go to chain restaurants or fast food places. They will have the nutrition information available from all of them, from coffee shops or coffee places to food places. Read what's in what you're eating. The biggest thing, as you mentioned, is sodium, especially soup, condiments, and things like that. And most Americans do get too much sodium. And it's really important, of course, to drink water when you eat more sodium or ingest more sodium. But we do tend to have too much of that. So the nutrition facts panel should be the first thing you go to when you pick up a food. Maybe after you've decided the price, or as you said, Fran, you're standing there and there's 3 or 4 different choices. I have to do the same thing. A lot of us get attracted to the marketing or like the advert, what's on the label, the pretty stuff. Don't worry about that. And don't worry about the claims that they make even. Get past that, jump right to that food label. Look at the sugar, look at the fiber, the saturated fat, and the sodium. And some of you might have to look for other things like if it's phosphorus, potassium, things like that. But for most individuals, those are the things that are targeted that you should be looking at.
And Kelly, I'm going to ask you one more question before we talk about your office hours and taking in patients. Holiday snacks. What are some alternatives? Charcuterie board, those cheese and cracker boards are just loaded with lots of no-nos, correct?
They are, but you will find one at my house when I have a holiday party. It's having options. So when I put cheese on there, I also put lower fat cheeses on there. I have nuts and I will add, and I don't have like honey roasted, sugar coated. I have raw nuts, maybe lightly salted. I like to put olives out. You will always find grapes or apples on my platters because I like to have those fruits mixed in. When I have crackers, I also give the option of seeded crackers, whole grain. I'll throw, in a sense, like those Triscuit or wheat thin, and there's versions of them out there, but those higher fiber crackers. So I always put them on there. Yeah, there's a way to make it healthy, actually, or healthier. But if you're asking for an alternative, vegetable platter, always, always, always be mindful of the dip. But when you're making dips and appetizers, if you can cut down on the butter, if you can do lower fat using fat-free or low-fat sour cream, lower fat cheeses, that's how you save. Cut down on the sugar when you're baking.
Yes. You know what? And I do that a lot. And people will still say, those peanut butter cookies are so good. But I don't tell them that I cut down tremendously, with the nuts. So with the nuts that I cut down tremendously with the sugar. And I don't want to miss one of the most important parts. If someone wants to meet with you, find out more information, because we just skimmed the surface today about nutrition and diet. So if someone wants to get in touch with you, how would they do that?
Sure. There are a couple things. So to meet with myself or anybody else on my team, the dietitians and my entire team, we're all diabetes educators as well. Or if you are interested in attending diabetes classes, you do have to be diagnosed with diabetes. But the option is you can either go online to the general physician website, which is gppconline.com. The other thing you can actually do, though, is call this number. It is 716-800-2273. So that is 716-800-CARE, C-A-R-E, which equals 2273. And it's option 5 to speak with our admin assistant, Christy.
What should they bring with them?
So before that first visit, the biggest thing, and our admin, she will take care of this. For some patients, you will need a referral from your doctor. I have never had a provider not provide a patient with a referral to see a dietitian when they ask for it. But we will ask for labs. So we want to look at what's your lipid panel, glucose, A1C, renal function. We like to look at all that, and definitely a list of medications that you are prescribed, and we'll talk about if you're taking them, even though they're prescribed. But those are the most important things for us. She'll gather insurance information, but for us, I like to look at medications, labs, and then if you want to bring even questions that you have, and then write down typically like what a day or two looks like, what you're eating, because that we're going to ask you that anyway. It's really helpful.
I was just going to say, should they put something like what favorite foods that they enjoy eating? What are the favorite foods they enjoy eating? Would that be helpful?
Absolutely. And we'll dive in with our questions because we look at the whole picture. Who else is in the household? What equipment? We look at everything. But yeah, anything like that. Like these are important foods and I would like to not have to give these up. How can we modify things? Yes.
Yeah. And just a quick funny story. I remember when my mother, when she was living, my father and I would not buy sugar because she would turn anything. She would have a prune pie. She would turn anything into sugar. And we knew that she was pre-diabetic. Well, she was type 2 diabetic with diabetes. And we just used to laugh. And she always got a kick out of telling everyone that we would not bring sugar in the house. Yeah. So, but anyway, Kelly, I just want, and give us that phone number one more time.
Sure. 716-800-2273. So 716-800-2273.
And what would be your message about just your one word message or 2 words about eating during the holiday season with type 2 diabetes or pre-diabetes? What would you say? What's your tip that you stick by?
So the tip to stick by is make sure to enjoy the holidays. Doesn't mean you cannot have your favorite foods. Have them in a small amount. Like you can have a taste of something, but still try, again, my 80-20 rule. Try to keep 80% of it healthy. Allow yourself that flexibility, and don't feel guilty about enjoying the holidays.
All right. Well, I want to thank you, Kelly Cardamone, for being our guest today on the Great Lakes Health radio program. And our topic has been type 2 diabetes, eating during the holidays and New Year's, and pre-diabetics. So I want to thank you for being our guest.
Thank you.
And I want to also thank our listeners for listening to the Great Lakes Health radio program here on Power 96.5 FM, 1080 AM. And in 2 weeks, God be willing, you will be hearing from me, Francesca Messiah from Kaleida Health, Manager, Workforce Development. Bye-bye.